Good afternoon, everyone, and thank you for joining us with our virtual series, Envisioning Equity Healthcare. My name is Carla Bautista, and I'm a second-year Master of Public Health student interning with the Office of External Affairs. Here at the office, we strive to be a bridge between the Baylor University and the Waco community in 5 different areas: city growth, cultural wealth, economic development, education, and health. Today, our conversation will be around health and healthcare inequities in our communities. We thank you for joining us. We would like to let you know that this webinar is being recorded for future view. Today was made possible with our partners, the Medical Humanities Program at Baylor University, at the College of Arts and Sciences, the Center for Church and Community Impact with the Diana R. Garland School of Social Work, and our office, the Baylor University Office of External Affairs. Next, please. Today, we will be presenting and hearing from Dr. Song, and he will be talking about how the COVID-19 pandemic has exposed the real inequality in our healthcare system and how we can do better. This conversation will be exploring the current state and problems of the US healthcare system and how the COVID-19 pandemic has further exacerbated the underlying inequality and solutions to address and improve healthcare inequality. Next, please. Dr. Song is a physician, healthcare activist, and biotechnology chief medical officer. He is a grandson of the late Sang Don Kim, the very first popularly elected mayor of Seoul, South Korea. Dr. Song is the president of Physicians for a National Health Program in California and served as the very first visiting fellow on healthcare policy in the California Department of Insurance in 2013. He was also the executive chairman of the Courage Campaign from 2010 to 2013. Next, please. We are also joined by Dr. Stephanie Body, assistant professor of church and community ministries at the Diana R. Garland School of Social Work here at Baylor. Next, please. Our next moderator is Dr. Lauren Barron. She is the inaugural Michael E. DeBakey, Selma DeBakey, and Lois DeBakey Chair for Medical Humanities and Clinical Professor and Director. Next, please. Before we begin our conversation, we would like to establish a foundation with these 3 terms: diversity, inclusion, and equity. Diversity is a presence of differences that may include race, gender, religion, sexual orientation, ethnicity, nationality, socioeconomic status, language, disability, age, religious commitment, or political perspective. Inclusion is an outcome to ensure that those that are diverse actually feel welcomed. Inclusion outcomes are met when you, your institution, and your program are truly inviting to all, to the degree to which diverse individuals are able to participate fully in the decision-making processes and development opportunities within an organization or group. Equity. This is what we're trying to advance in our communities. This includes elimination of policies, practices, attitudes, and cultural messages that reinforce differential outcomes by race or fail to eliminate them. Equity is promoting justice, impartiality, and fairness within the procedures, processes, and distribution of resources by institutions or systems. Equity is a condition that would be achieved if one's racial identity no longer predicted, in a statistical sense, how one fares. When we use the term, we are thinking about racial equity as one part of racial justice, and thus we also include work to address root causes of inequities, not just their manifestation. Tackling equity issues requires an understanding of the root causes of outcome disparities within our society. It is through the Envisioning Equity series that we hope to gain a better understanding of the root causes of disparities within our system and discuss possible solutions for eliminating them. And now we will have Dr. Sung join us in this presentation.
Hi, how are you? Well, again, thank you so much for allowing me to be here today. What I wanted to do today was to really share with you sort of how I arrived at the feelings that I have about our healthcare system, but more importantly, give you lots of information that you can take to really independently digest and analyze yourselves. I would like to make my talk available to anybody who wants that, and we'll forward these slides on to you. But I just wanted to first start with this. This is the section of the Hippocratic Oath. So about 30 years ago, this May, I was asked to raise my right hand and repeat the Hippocratic Oath. At the time, C. Everett Koop was the Surgeon General. and he had come to our medical school graduation to administer the oath. Now, I didn't remember much about the oath from the time, but I did remember this part that said, "I will follow that system of regimen which, according to my ability and judgment, I consider for the benefit of my patients, and abstain from whatever is deleterious and mischievous." And I would argue that after that, I became an oncologist. And I started to see a system that was far too deleterious and mischievous for my own patients. A lot of people who develop cancer, 1 in 3 patients, have to turn to a friend or family to pay for care. They run into significant problems with debt, medical related bankruptcies once they survive their cancers. And unfortunately, many of them not only succumb to their cancer, but leave their families with tremendous financial cost and burden. And I started to wonder, how is it that we have a system that is supposed to be the best system in the world that allows patients, when they get sick, to suffer such financial harm? So I started to question everything I had been told about our healthcare system, and independently started to look at what our system was doing well and what our system was not doing well. So a couple other things about the financial aspects of our healthcare system. We have, as a society, tried to do quite a bit for our uninsured, maybe not as much as I'd like to see, but I'd like to really focus just for a minute on the people that have insurance. And if you look here, these are people that supposedly have insurance, which is supposed to protect us when we're sick. But if you look at the number of people when they got sick who reported using up all of their medical savings, it's 63%. The number of people that borrowed money from friends or family was 37%. And the number of people that were unable to pay for food, heat, or housing was 34%. And I began to ask, how again does this happen when you have insurance that it cannot even protect you from basic day-to-day costs of living? So as a result, on the left, it just shows you that we as a society spend roughly twice as much per person on healthcare as any other industrialized nation, and a larger percentage of our gross domestic product. And yet we have a lower life expectancy despite paying all that. Above on the right just shows you again how much we spend on healthcare compared to the other industrialized nations. And down below, it also shows you again the number of people, percentage of our society that have difficulty with medical bills. So something's not right. It's not that we're not paying enough for the system, but we're just not maybe getting the best care that we deserve, and certainly not the financial protection. Um, the other thing is, despite the fact that we spend twice as much per person as every industrialized nation, if you look at our life expectancy, we're on the lower third. If you look at our infant mortality, we're at near bottom of that. If you look at our ability to have safety during childbirth, again, it's quite low. And in fact, if you look at the maternal mortality, it's no other country is close in terms of the maternal mortality that we have as a nation. And when you think of states that are trying to reduce a woman's access to care, and sort of legislating pro-life types of legislation, but not giving these same women the healthcare they need to take these pregnancies to full term, it's no wonder that we have a maternal mortality rate as high as it is. So just to give you all a little summary of the various healthcare systems, because you'll hear terms that are thrown out there, I wanted to just sort of explain what the various healthcare systems are and the countries that have that. But ironically, here in the United States, we actually have components of many of these healthcare systems. So you hear a lot of times people say the term socialized medicine as if it's an awful, awful system. A socialized medicine system is basically where the country owns and operates every aspect of the healthcare system. They own the hospitals, they employ the doctors and nurses and the pharmacists and the laboratory technicians, they own the radiology equipment. Every single aspect is owned and operated by the country. And you have systems like that in the United Kingdom, Denmark. You also have countries that have employer-sponsored healthcare, which is countries like Germany. You have countries that have single-payer healthcare, where the government acts as the sole insurer, and then you see that in Canada and Taiwan and Korea. And then you have countries that have uninsured for everyone, which is like Burundi and Myanmar. And here we have roughly 33 million people that are uninsured in the United States. Ironically, the socialized healthcare system that we have in the United States is our VA system, or our National Indian Health Service. And it's ironic that the people that fight for our freedoms are covered under a socialized system. So it can't be all that bad when you hear about that. So the Affordable Care Act was signed into law now over 10 years ago, and it did do quite a fair amount of good things. The things that I think, from my standpoint, really stand out the most is that it made preventative care free in terms of screenings for mammograms, vaccines, and checkups and colonoscopies. It did away with the bias against pre-existing conditions. Believe it or not, prior to the Affordable Care Act, being a woman was a pre-existing condition. There was no, also there was a cancellation on lifetime caps. So as an oncologist, I used to see occasionally some patients who had been fighting cancer for 5, 10 years, and they had used up the full amount of their insurance coverage and were really on their own. But now there is no lifetime cap on coverage. So the Affordable Care Act did do some good things, but because of the heavy corporate influence, there were 3,300 registered healthcare lobbyists for the 535 members of Congress, and they spent more than $1.2 million a day lobbying our Congress. We did not get insurance rate regulation, we did not get drug price controls, and we didn't get a public option. And in fact, the Lancet, which is a highly reputable medical journal, took the unprecedented steps of publishing an article that said the healthcare reform process exposes how corporate influence renders the US government incapable of making policy on the basis of evidence in the public interest. And instead, they were greatly swayed by the lobbyists in DC. So as a result, as I mentioned, the Affordable Care Act did a lot of good things, but here's some things that have continued to happen since the Affordable Care Act was put into place. First of all, there are a lot of people who get their coverage through their employers, and many people don't necessarily like their job, but they're stuck in a job because it gives them healthcare benefits. But in spite of that, this is just showing you that over the last 10 years, the number of employees who get their coverage through work have been asked to contribute more of their paycheck towards their employer-sponsored healthcare on the front end, so they have had less take-home pay. And on the back end, when they get sick, they've had to pay dramatically more in terms of copays and deductibles. Meanwhile, inflation and overall earnings have remained stagnant. The other part is that if you look at the underinsured, and that means that if you were to get sick and your insurance plan maybe had a huge deductible, $6,800, or you had to pay 30%, maybe even 40% of all your expenses, chances are that you would not be able to financially meet the needs of your illness. And this is just showing you that among people with insurance, the number of underinsured, meaning that the paper that their insurance policy was printed on wasn't really worth much, had grown to 42% for people who got their coverage just an individual plan. And for those that had employee-sponsored coverage, 1 out of 3 people were underinsured, meaning that if they got sick, they most likely would suffer significant financial harm. And then there's something that has come up over the last few years, which is called the Healthcare Unaffordability Index. So what that means is when you take your family healthcare annual cost, you divide it by your median household income, it gives you an unaffordability index. And it's now at the highest it's ever been at roughly 30%, meaning that most of us have to spend a third of our household income covering our healthcare costs each year, which is really a pretty obscene. And then if we look at patients who have insurance but have put off care, so because your copay or your deductible is too high, you've delayed seeking care. And I see that all the time when I talk to patients as an oncologist. Some people come in with large neck masses, and they say that they didn't have the money to go pay for the ultrasound or the biopsy because of these high deductible plans. And if you look at how this affects our communities of color, it's disproportionately affecting communities of color compared to the white population. The other thing is, as I mentioned, we didn't get any drug price controls. And we've seen upwards of 45 million Americans every year reporting that they don't fill a prescription because it costs too much. And roughly 1 out of 5 seniors doesn't fill a prescription because of the cost. And yet Medicare remains prohibited from negotiating drug prices. So I would ask, why are we spending so much and getting so little? First of all, we have this very convoluted system, and some of you may experience each year. Maybe one year you have your coverage through United Healthcare, and then the next year your employer gives you coverage through Aetna, and then the next year you get coverage through Blue Shield, or maybe you lose your job and now you have Medicaid, or now you turn 65 and you go into Medicare. Well, the problem is when you go to see your primary care physician or you go to a hospital, they've got to figure out each time you change your insurance, am I in your network? What's your copay? What's your deductible? And then sometimes when they want to refer you to another specialist or admit you to a hospital, they can only send you to where your insurer now has a contract with that. So it's this very complex, convoluted system that adds unnecessary layers of administrative complexity and cost to actual care. Actually takes it away from actual patient care, but takes money away from money that should be used to actually be taking care of patients. And if you look from 1970 to 2015, in terms of just the sheer number of physicians that were trained during that period of time, it's remained relatively flat, which is the green line. But if you look at the number of administrative people that have been hired by the insurance industry, hospitals and things, basically to deal with claims or denials, you can see that that's just exploded. And down below, if you look at the changes in healthcare expenditure between the private insurance industry, it's no wonder that if you look, it sort of mirrors the increased number of administrators that have been hired over that period of time. And in fact, we spend more as a nation on administrative costs than any other country, and we spend far less on long-term care. And if you look at where our society, aging society is headed, it is where we need to actually put more money. So wouldn't it be nice if we put less money on administrative costs and more money into long-term care? In fact, I'm sure Baylor's, the whole Houston, where you have Baylor, MD Anderson, and all the hospitals are very similar to Duke, but there you can see how many beds they have versus how many billing clerks. And as a result, $1 out of $4 that a hospital takes in is spent on administrative costs. Again, think that money could be better used to add more nurses and add more ICU beds, or really do capital improvements to the hospital, but instead it's used to fight with insurance companies to pay for the billing of care. So it's no wonder that we have the least efficient healthcare system by far. And I just want to say how, given the background now, how COVID has further exposed a lot of these inefficiencies. And first thing I just want to say is, may we not grow numb to the number of deaths that have happened in the United States. We are now at 530,000 people that have lost their lives over the last year. It's astounding when you think about that, but I worry that we as a society have become numb to the number of deaths, and we just kind of brush it off and really don't have any real grasp of that. But unfortunately, this number is continuing to climb. And for those of you, if you have lost any friends or family, I share my deepest sympathies with you. But I think I would really encourage all of us as a community not to get numb to these deaths and to remain empathetic to this tragedy that is ongoing. Now, if you really look at it among racial disparities, if you look at the death rate per 100,000 people, particularly among our African-American community and our indigenous population, it's quite high. And if you look at, again, other communities have not been hit as hard, but I think definitely communities of color have suffered greatly and without any comparison compared to the other communities. And one of the things you heard during the Democratic debates when then Vice President Biden used the death rate early on in countries like Italy and other parts in Asia that had a government-run healthcare system as a way to slam that as not being an effective way to treat, sort of as a counter to Senator Sanders' plan for Medicare for All. You can see what's happened since now President Biden made those claims, right? The death rate in the United States has exploded, whereas in those countries that have a universal government-run healthcare system, they've kept their death rates quite low since that time. The other thing you see is that if you look at the frontline workers, and I know in Texas, just like it is here in California, the people that have continued to work during the pandemic, there are frontline workers, there are construction workers, cooks and drivers and cashiers and waiters and waitresses. They are some of the largest numbers of uninsured people, and yet they're on the front lines of this pandemic. And the other thing you heard during the Democratic debate was Senator Klobuchar say to Bernie, oh, you know, your healthcare plan is going to kick millions of people off their employer-sponsored healthcare. Well, look what the pandemic has done, right? A lot of people who got their coverage through their work lost their jobs and as a result lost their coverage. So again, a lot of these sort of lies that were perpetuated by the Democratic side of our political discourse turned out to be exposed during the pandemic, because the number of people who lost their employer-sponsored health care and their dependents is somewhere between now 14 and 20 million people. But look at the number of people who've lost health care in other countries that give universal government-run healthcare, zero. So I would really say the one thing that COVID has exposed is healthcare is a human right and not a job perk. And the other thing that you heard was a universal healthcare system would lead to rationing of care. But this was just from a month and a half ago here in California, that again, a lot of the safety net hospitals that have not been able to build out their infrastructure, not been able to add additional ICU beds or respiratory therapists or ventilators, ultimately ended up having to triage and ration care. So when you hear a socialized system or a Medicare for all system will lead to rationing of care, we have our current for-profit system that's already doing that. The other thing is that with regard to Medicaid, we have seen now that it's really exposed the separate and unequal system. Here in California, the amount of doctors that will actually take Medicaid is decreasing each year, partially because the reimbursements are so low. And as a result, if you are one of these people that has Medicaid, you have to wait a long time to see a doctor. And what COVID has again exposed is the number of people that have died during this period of time waiting to see a doctor. So I would argue that Medicaid, while it's done some good things, still remains a separate and unequal healthcare system compared to the private insurance industry and certainly Medicare. But here's one group that has done quite well during the pandemic is the private insurance industry. They've had record profits during this period of time. So just to give you a few words about where we are right now with our healthcare system, when Vice President Biden, then Vice President Biden was running, he wanted to, he was running on basically building upon the Affordable Care Act. He wanted to increase subsidies to people that were getting coverage. He wanted to reduce out-of-pocket costs and create a public option. And I'm not sure how many of you really have had a chance to digest and analyze the stimulus bill that just was passed, but it really has, while I'm very disappointed with the minimum wage provision and a few other things, I do think that it should be really noted that what's in this bill is pretty transformative for quite a few things. But from the healthcare perspective, I just want to point out that it's really done several things. It's expanded the Obamacare tax credits. So before, it was only if you were making less than 400% of the poverty line would you qualify for a subsidy. But now there is no maximum cap. And chances are there are several of you, if you get your coverage through an exchange, that would qualify for a subsidy. If any of you have lost your employer-sponsored health care, and are on COBRA, the stimulus bill will allow them to pay for your COBRA at least through September, which is really positive. And then also, it's greatly expanded Medicaid. So in states that have not expanded Medicaid up to now, the government is actually giving a strong incentive. They're willing to pay states more than what it costs to implement Medicare. So up to now, under the Affordable Care Act, they would get 90% of the cost of Medicare. But in some states like Mississippi and else, they'll actually almost get 1.5 times what it costs to insure. So we'll see how many of these governors remain resistant to expanding Medicaid when it is basically free money plus additional money to their states. But here are the existing problems of our healthcare system, right? We still have 31 plus million that are uninsured. We have no real coverage for our undocumented brothers and sisters. We have no insurance rate regulation. We have no drug pricing controls. We have narrow networks, which mean that chances are if you have a plan, it only lets you see 25% or less of the doctors in your existing neighborhood. We still have high copays and deductibles. We have the administrative waste that I talked about, and we have an overall inefficient healthcare system. And especially, we have still a lack of health security with job loss. So President Biden wants to push a public option. It would be a government administered plan. We would still have Medicare, Medicaid, and employer and marketplace insurance. The question will be whether or not this will pass. It has already been estimated that a public option would add $700 billion over the next 10 years to the federal deficit. So let's look at 1965. So that's me and my dad. I was born 2 weeks before Medicare was signed into law, which is on the right. Just to show you that Medicare, despite the fact that it takes care of an older population with more chronic medical conditions, more in poor health, that it still does a better job at controlling costs compared to the private insurance industry. And instead of sort of this convoluted plan where you have multiple payers and multiple copays, deductibles, networks, and things, what a Medicare for All system would be is a single payer plan where you just have one sort of insurance company for everyone that simplifies it. So whether you change your job, you'll have the same insurance card. Whether you are employed or unemployed, you'll still have that. Whether you're 65 or 5, you'll still have the same coverage throughout your whole life. And so if I had to diagnose one of the problems, I would say if we could remove sort of the complexity and an industry that is basically siphoning money away from actual patient care, perhaps we could make our healthcare system a little bit more robust. So when Senator Sanders pitched his initial Medicare for All plan, they went to town, both not only on Fox News, but also a lot of Democrats said that it would bankrupt our country, that it would cost $32 trillion over 10 years. But what's ironic is they did a poll on Fox and Friends, and they said, would the benefits outweigh the cost? And the majority of their viewers said yes. But here's the reality of a Medicare for All plan. What they failed to mention was the Mercatus Institute, which is a very conservative think tank at George Mason University, did a study on Senator Sanders' plan. And yes, while it concluded it would cost $32 trillion over the course of 10 years, they also found that it would save $2 trillion compared to doing nothing. If we just stayed with the status quo, it would cost $2 trillion more. Whereas Senator Sanders' plan would ensure everyone, increase the benefits for the aging population, and still save $2 trillion. But you never really heard that said by anyone. So on one hand, you have a public option that will only expand healthcare for just a very few, costing $700 billion over 10 years, and yet a Medicare for All plan, which would ensure every single person would save $2 trillion. But yet we don't seem to have the political will to do this. So just to point out what the difference between a Medicare for All option versus a public option is Medicare for All would cover everyone, where a public option would still exclude our undocumented brothers and sisters. Medicare for All would not be tied to employment, where a public option would not eliminate the employer-sponsored coverage. Medicare for All would eliminate copays and deductibles. Public option would not. Medicare for All would allow you to see any doctor, any hospital, anywhere, whereas public options would still maintain those narrow networks. Medicare for All would reduce federal spending by $2 trillion over 10 years, whereas a public option would add $700 billion over the next 10 years. And a public option would still have all that administrative waste because you still have all of the other insurance companies, Medicare, Medicaid, and such, whereas Medicare for All would just have a single payer, so it would simplify everything. And Medicare would also negotiate deep discounts in drug prices and cost of services, whereas a public option, because it's very fragmented, everyone would be left to negotiate their own prices. So just want to say one thing about somebody who was a hero to me and my family. So Shirley Chisholm was the first African-American woman elected to Congress. But before she ran for Congress, she ran some preschools in sort of the harder hit communities of New York. And my mom came to the United States in 1951 as a refugee during the Korean War. She would eventually graduate from Columbia Teachers College, and the first person to hire her was Miss Chisholm. And Miss Chisholm actually took my mom under her wing, became her mentor. And then when Miss Chisholm ran for Congress, she asked my mom to go apply for the director of Head Start in Newark, New Jersey, which my mom ran for 20 years. Miss Chisholm in 1972 ran for president under the mantra of being unbought and unbossed, which I wish more of our politicians today were, meaning that she refused to take money from corporate influence and she would just do what was right. In 1972, she said, "We have never seen health as a right. It has been conceived as a privilege available only to those who can afford it. This is the real reason the American healthcare system is in such a scandalous state." Sadly, this is now almost 50 years ago, right? And these words are more true today than they were in 1972. And when people say we can't afford it, we don't have the money, I would just point out this study that basically showed that here in California, for all of the healthcare costs that we're spending, 70 cents is already paid for by us, the taxpayers. When you look at tax breaks to Google and Apple to give healthcare to their employees, when you look at covering our public servants, whether it be our police officers, firefighters, teachers, that's all being paid for by us, the taxpayers. And yet, despite the fact that we're paying for 70% of all the costs, and you have the insurance industry taking roughly 30 cents of every healthcare dollar away from actual healthcare on administrative costs, marketing, sales, the money is there. We're just not getting what we pay for. And during the primaries, you heard some people say giving healthcare for all was like giving everyone a pony, but look at all of the countries that give ponies. And I would say, where's our friggin' pony? This is my daughter and I 2 years ago during Halloween. But just to say that I think it's possible, but what we need to do is understand and educate what's wrong with our healthcare system and what we need to do better. So with that, I just want to thank you for your time. Sorry to rush through all this. I know it's pretty dense, but I do want to make these slides available to anyone who would like them, and happy to take any questions. Thank you.
Well, thank you so much, Dr. Song. Dr. Body is going to be joining us here in a second. I just want to thank you for this. There's so much to think about, so much to talk about, and delighted to have people from the community, from the medical community, our students with us today, and want to encourage you to share your questions and comments. And I think this is going to be a great opportunity. Dr. Body, would you like to lead with the question? Get everybody warmed up?
Yes, again, thank you, Dr. Song. This was a very interesting presentation, and for those who have not thought about it this way, I guess the question that I would have for you is, how do we begin to think about what is it that we want to gain in terms of healthcare? I think it's easy to see the challenges of giving up the system that we have today, but can you speak a little bit more about what we have to gain by thinking about some of the challenges of our current system and what we could hope for in a post-COVID world if we were able to dig a little bit deeper and see some of these challenges in our system?
Absolutely. First of all, I mean, while ultimate goal for me would be to see a Medicare for all plan, I think right now we need to do whatever we can to make sure that the communities, particularly communities hit hardest and left behind, are getting the access to care that they need. So there is, as I mentioned in the stimulus bill, there is more funding for community health centers. There's more funding for people who've lost their jobs to go get COBRA coverage. Right now, they'd had to pay for things out of pocket, and many people, because they lost their job, couldn't afford to even pay for COBRA. But now you're able to get coverage for that. There's a lot of incentives for states to expand Medicaid, particularly those states that have been resistant to do so. So I think those are the frontline things that we should really tout and really support, because they will actually help people today in a tangible way. Um, with regard to the more broader picture of escalating health insurance costs and pharmaceutical costs and things of that nature, I think if you're somebody right now who's uninsured or underinsured, that's not really your big issue. Your big issue is just being able to get access to care. So I think in the absolute front lines, that we have to be practical, and those are the areas that I would say, that are crucial to continue to support. And I think the stimulus bill actually does a large part of at least helping to do that. On top of the child care credits that people are getting for a lot of the talk about equity, right? A lot of women have lost their jobs. More women have lost their jobs than men, much more disproportionately. And the burden, particularly those that are having to homeschool their kids and be home and not be getting any ability to go back into the workplace. The child care credit for that is in this stimulus bill, I think is pretty substantial. All of these things will contribute to a healthier society. And I think those are the things that we should really focus on right now. But as we move long term, I think our current healthcare system is unsustainable. And we do need to really push for a more full, equitable system, like Shirley Chisholm said. But until that, right now, I'll gladly take what the stimulus bill has given us over the last just in the last day and a half.
Okay,
I'd
great.
like to ask a question. We have some physicians from the community and people working in healthcare on the session today, and we know that we have other colleagues who are going to want to watch this presentation later that couldn't be with us today. But I'd like to ask about the two words, physician and activism. And the reason I'd like to ask about that is because I have been flailing around trying to find ways to be an activist in this regard. And I'm going to give you one example, and that is the fury that I felt when a insurance company denied a patient who'd seen the same cardiologist for 25 years and now says that cardiologist is out of network. The cardiologist is upset, the patient is upset. And I sent a 3-page letter to the insurance company, which kind of concluded with the fact that it made much more fiscal sense for the patient to see her own cardiologist, who's less likely to do another echo, another cath, another nuclear stress test. And besides that, it was a violation of the doctor-patient relationship without the consent of the doctor, without the consent of the patient, and that I refused to recognize the sovereignty of some so-called network. So that the patient ended up getting to see her cardiologist. That took a few years off of my life, probably just the anger that I walked around with. And even though I enjoy writing a letter like that to a certain extent, and I am absolutely justified with righteous anger, it's only one letter. So how can we really be effective activists in healthcare? Where can we really find that lever?
Well, I will say that your activism there is commendable, because I do know that the average doctor spends 20 hours a week fighting with insurance companies to get pre-authorization or advocate on behalf of patients. If there was a way that more doctors could come together to not be dropped out of network, to work with legislators to legislate such laws, I think that would be one way that people could get involved through their medical societies and such. I think probably in talking to a lot of friends that I know, they're so exhausted when they've seen a full day of clinic and been on the phone that the last thing they want to do is then go do something. And they tell me, I advocate every day for my patients because I'm always on the phone fighting to get this x-ray or this test or whatever. But that's time and energy that's being wasted from us actually taking care of patients, right? So if there was a way that the medical community, they may not agree with me on Medicare for all, but I think they would agree with what you just mentioned about being dropped out of network and all of those things, could coalesce, work with the Texas Medical Society that I would imagine would have some sway in Austin with the government to really pass legislation to prevent such serendipitous dropping, right? It's just unilateral. It's like I'm breaking up with you without even telling you until you
Right.
go, right? So I think that that is something that I would encourage physicians who may not agree with me on other things, but at least for that, we could find common ground to work together and try to do that. But thank you for continually advocating and doing that. I mean, I know it's exhausting, but unfortunately, if you're not able to do that, the patient really doesn't have much power because, as you know, they'll get worked up a chain and insurance companies deliberately try to make it so burdensome that eventually they don't want to even stay on the phone for 2 hours to wait to talk to somebody, right? So they give up.
Absolutely, absolutely. Dr. Body, would you like to ask these next questions? Are you able to see those?
Yes. So the next person says, this information is so true. I've often thought about these ideas, but you've organized the facts and figures in such an amazing way. It is so ironic that we can build on the COVID pandemic to create positive change. In this country, when and where did we go wrong? And how come we did not see healthcare as a right when other countries were moving in that direction?
It's a good question, and it's one that I constantly scratch my head each day. But if you again look at the history of healthcare in the United States, there's an amazing movie out there called Fix It, which is moderated by Danny Glover, which talks about the segregation of our healthcare system up until the institution of Medicare. So Lyndon Johnson in '65 not only had Medicare, signed Medicare into law, but he specifically strong-armed hospitals that had been segregated to that point to see anybody, regardless of color, otherwise they wouldn't get funding. And he had to use that sort of strong arm approach to finally break the segregation that exists in our healthcare. But if you look at it, it's all based, I think, rooted on racism, rooted on inequality, and deliberately keeping a certain element of our society unequal that has really continued to contribute to our healthcare system as it is. But I think if you want to see sort of the glimpses of where the healthcare inequality really were perpetuated, you really should see that movie Fix It. It's remarkable. It'll make you just get so angry, but at the same time, give a whole nother respect to President Johnson for how much he fought for that.
Mhm.
And again, for those of you who would like my slides, because I know it's very dense, there was a lot to digest, I will forward that on to you all, and you can share them and use them however you see fit. Feel free to scrutinize them. If you see anything in there that you don't think is true, feel free to reach out to me and correct me. I like to think that anything we put up there is really peer-reviewed data, but really want to make that available to all of you.
Thank you.
Thank you. You know, a lot of our university and a lot of institutions, healthcare institutions in particular, well, all institutions right now have diversity, equity, and inclusion kinds of initiatives and curriculum and professional training and at all different levels. And we're certainly dealing with that here at Baylor University and also in the Waco Family Medicine, the federally qualified health center where I work. One of my questions is, you and I have been doing this about the same time. You mentioned 30 years. I tell people I didn't train in this century. I didn't train in this millennium even. But you know, it's not uncommon for us to work alongside incredible physicians. I mean, just fabulous doctors that we would be happy to go to, or we would happy to send our family to, and have this question of why are we talking about equity all the time? I do the best for every patient that's in front of me. You know, I think the subtext is, well, I'm not going to say what the subtext is, but just the idea that why are we, you know, sort of like fatigue, like we have Zoom fatigue. It's sort of like equity, inclusion fatigue. So what would you say to some of your colleagues in medicine that have that sense of, hey, I take care of every patient the same, so why are we still talking about this?
It's interesting because for everyone that you mentioned that speaks that way, I've actually seen others during this COVID pandemic have their eyes exposed to the disparities that exist. So why is it that certain communities have a much higher death rate? Is it because there's a genetic predisposition, or is it because they have less ability to control their diabetes or their hypertension? It's not clear, but I will say that the death disparities, that slide that I showed you, uh, without a doubt highlight other inequalities within our healthcare system for those same communities, particularly the African American community and the Native American communities. And if you go back and then take a step back and look at those communities in terms of overall access to care compared to other communities, you'll see that there has been far less access. So it's no wonder that if a community is not kept as healthy as others, they're going to be more susceptible to this pandemic. So I've seen actually other people say, wow, this does expose what we need to do more. Certainly, I've heard people that have echoed what you said. Why everything is fine. Like we just need to do our jobs. But I think people are waking up to just the overall sense of inequality in healthcare because so many people have lost their jobs. Also, employer-sponsored healthcare. So before I know so many people who were sort of on the moderate to conservative side who didn't want Medicare for all, but now they've lost their job in their healthcare and they're like, wow, maybe your idea wasn't so bad. And I think when you start to personally experience these problems, you start to realize that maybe the healthcare system isn't as great as you thought it was.
Right.
Yeah.
Here in Waco, Texas, we have a large population of Hispanic and African American community, but we don't have a large Asian community at all here, like in California and the Pacific Northwest. So I was wondering if you might be willing to say something, help me know, as a family doctor and as somebody who's working with pre-med and pre-health students, could you comment on the experience of the Asian community, especially in terms of, some prejudice associated with the virus and, your experiences in rooms with patients? Could you help educate me about the Asian experience?
Well, certainly right now there has been an uptick in Asian related hate crimes, and certainly calling this and I'm Korean, but calling this a China virus didn't help. I do think that with regard to Asians and the overall infection rate, many people took masks more seriously because in Korea and Taiwan, Japan, during flu season, they just all wear masks. They've been doing that for the last several years. So when coronavirus hit, they just automatically started to do that. So I do think there's been a lot more taking the masking seriously. So that can contribute perhaps to the infection rate being slightly lower among Asians. But I also think among Asians, there are a number of Asians that are uninsured. A lot of these people are small business owners and have not been able to get coverage, or now that business has slowed down for them and they've had to close. When I think of the dry cleaners, when I think of the convenience store clerks, a lot of them don't have coverage. So it is a challenging situation. I do think, though, in terms of the environment right now, I think we have to try to meet communities that are feeling at odds with the Asian community and have an honest dialogue about things. So my best man, my best friend, his dad was the first Black lawyer in the Department of Justice in the Antitrust Division. His mom was the first Black woman elected to the Fairfax County Board of Supervisors in Virginia. This is my best man. And we have these honest discussions about sort of what's happening, because it looks like certainly in parts of Oakland. A lot of the attacks on Asians have been perpetrated by members of the Black community, but it shouldn't become this race thing. I think we need to have a deeper understanding, not make it so, make it about that. But ultimately, we need to have honest discussions. We need to have a dialogue and talk with each other instead of talk at each other or beyond each other. So, my hope is that now that there is awareness about the increased uptick in Asian crimes, like it's up 150% in California and New York. It's only in those real states. The rest of the country's been pretty good. It's pretty scary because when you see the elderly, I have an 89-year-old mom, the mom I told you about that worked with Miss Chisholm. We've told her to stop walking by herself now. It's, because of that.
Hmm.
Sorry to ramble, but I just, along those lines, I view that as an issue. But I also think, again, there's a deeper issue when I look at this. When I look at prior race riots, things of that nature, there needs to be a closer working relationship between people that move into other communities and profit of those communities, but maybe don't give back to those communities. There needs to be a real give and take there. And so that's how I think when you become good stewards and you become good neighbors, you don't build that animosity that then somebody feels like they're going to go take it out on you when they're feeling down. So, but it's a tough situation. Yeah.
Yeah. Dr. Body, would you like to pose this next question?
Yes. So we have a question in the queue, but I actually want to ask a question that's related to our class. As Dr. Barron shared earlier, we're teaching a class called Disrupting Racial Health Disparities. And we have medical humanities students, social work students, and seminarians in this class. Students, some are going into the healthcare professions. More specifically, some will be working in other arenas. But my question is to you, particularly as you've stressed the waste and inefficiencies in our system, what disruptions or innovations do you see that non-physicians can help to support as we work together to create a better healthcare system?
At its core, we need to get everyone who's on this call to run for office. And we need an army of Shirley Chisholms in office. And I mean, in terms of people that are unbought and unbossed, that just want to do what's right and not listen to who's giving them campaign checks. Because until we get that, we're not going to bring about really any really meaningful, impactful change in Congress. So I would say that if any of you is interested in running, that you should. If not, then you should organize and make sure your voices are heard among your local elected officials. I mean, look, we saw what happened in Georgia, and it's possible, right? So I think recognizing that collectively we do have a voice, but it's hard to overcome sort of the corporate influence that really continues to strangle our elected officials. So I would say I'd like to see more people run for office that really champion the people and things that will help people versus helping corporations. The other thing is, I think, continue to learn, and then I call it spread the gospel, like go and teach people about what's good and bad about our healthcare system. Because chances are the most people you're in our families or our neighbors or coworkers know very little about what's good and bad about our healthcare system. So the more we can all learn about it and educate and share with people, I think the better. And certainly from a doctor perspective, I know now, our days are slammed seeing patients, but if you have the ability to share with them aspects of a healthcare system, they listen to their doctors. They believe in what the doctors mostly tell them. So I think we need to do all of those things.
Are you running for office anytime soon?
I am not right now with two young kids, but I will. But I certainly tried my best to support and advocate for those that really stand up for things that we believe in and that will help. I'm constantly trying to find the next Miss Chisholm.
Yeah, yeah, right. We have a question here about what types of organizations can lead the charge, you know, to organize community discussions and town halls. Colleges, government agencies, nonprofits, healthcare providers, other types of organizations that can champion these community outreach and education movements. And this is a great question because you understand the complexity of just healthcare by itself, not to mention the complexity of all of these other institutions. So do you have thoughts about how these coalitions can form and come together and who should be leading them?
Well, it's a great question, and certainly in California. So we've been trying to pass a single payer bill for a while. In the beginning, when I was first involved with this, maybe 10 years ago, the majority of people that were advocating were really like a bunch of hippie Berkeley doctors. But what's happened since then is healthcare has affected so many people, right? So communities of color, our undocumented brothers and sisters, which we have quite a few in California, and like you all have in Texas, are people that have insurance and almost had financial ruin despite having insurance and getting sick. We were able to bring all of these diverse communities together to advocate for something greater. So I think that's what we should you just continue to do. Now in Texas, I know there are groups that advocate for many equitable solutions, not just on healthcare, but education and I think the more like Baylor's, the students there could probably get together with students elsewhere in the state and really start to grow this. But I do think it really starts with the students right now. It's just impressive to see how much the students care more about themselves than maybe the generation that we grew up in, for sure.
Great. Our next question asks, can you speak to Shirley Chisholm's unbought and unbossed for our audience members who are of various ages, please? This member, she saw the documentary by the title and is working through it now, but wonders if the audience members fully understand the unbought and unbossed message that you so eloquently spoke of. Can you say more?
Yeah, so again, what's so, why Miss Chisholm again is so dear to me and my family was she was the first person to hire my mom after she graduated from Columbia Teachers College and really mentored my mom for almost about 7 years. But Miss Chisholm was so ahead of her time. So for a lot of the preschools in Harlem, where she was a director, this is in the late 50s, early 60s. She was as a Jamaican woman of color, started to make people like my mom and others learn Spanish because she started to see the changing demographics in Harlem. There was a lot more Puerto Rican influence and such. So my mom, as an early teacher after work, they would all have to take Spanish classes. This was sort of the forward thinking of Miss Chisholm. She was much more multicultural but she was also very aware of the influence that special interests had on our government. So from the time she first ran for the New York State Assembly and then became the first African-American woman elected into Congress, she refused to take corporate money, lobbyist money, that just like we see today. And she always had this mantra of being unbought and unbossed, meaning that most politicians are bought by the campaign donations from, whether it be in healthcare, the pharmaceutical industry or the private insurance industry, and then they're bossed. They're being pushed to support this legislation or not. And she just said, I'm not going to be bought by anybody, and I certainly won't be bossed, so I can always advocate for what I want to do. The other thing about Miss Chisholm is if you look up her quotes about gender inequality, where she said basically the women are told experience sort of discrimination and gender inequality the moment they're born, and and the doctor says it's a girl. Like, she recognized all of the issues that women faced, and as a woman of color back then, but just in general, you should really, when you get a chance, just Google her quotes on women, and you'll be just amazed. And again, as the father of two daughters, I look at those, and especially right now, this month is Women's History Month. People should really look at her teachings, her quotes. They should go back and look at some of her videos. She was a remarkable, remarkable woman. And to run in 1972, right, for president, she didn't get very far, but she was pretty just an amazing woman that I wish more candidates could emulate.
Wow,
Yeah.
absolutely. Are there, I'll ask this question. Are there perspectives that you have, you mentioned as an oncologist, especially some of the financial toxicity, which is a great phrase. You know, a lot of us hear the word oncology and we think chemotherapy, but there are other kind of toxicities. Do you think being an oncologist has particularly shaped your views, or do you think if you'd been in another specialty that you would? I'm just wondering how the field of oncology has helped shape your views specifically.
Yeah, so a lot of people are shocked that, because most people, doctors that seem to advocate for Medicare for all, tend to be more frontline pediatrics, primary care, internal medicine. But as a radiation oncologist, I had a pretty sweet life early in my practice. Made partner, was making more money than I ever anticipated as a physician, right? You don't really know. I mean, certainly had a great relationship with patients, and really found a lot of joy in taking care of these patients. But inevitably, you get very close to your patients, because as they're going through a really profound, vulnerable time for them, um, either you could be sort of cold, or you can really grow attached. So early on, I started to see so many of my patients struggling to pay their rent, or having their house foreclosed. And this was before there were bans on lifetime caps, or being denied care, which the insurance industry was much more apt to do with experimental treatments back then. And I had two choices, right? Like, I could just go home and enjoy my life, or I would just be so upset all day because I would see these people that were suffering enough emotional and physical harm, and then to have the financial harm and the stress that came along with that. So probably about 3 years into practice, I started to realize I just couldn't continue to just blindly participate in a system that was broken and frankly immoral. And I will tell you that when I started to become much more outspoken in terms of my advocacy, there were probably some doctors that stopped referring patients to me, because they said, "Oh, I'm not going to send it to the socialized doctor," or, that type of thing. But you realize that just as you're all doing right now, you can either remain silent, or you have to take a stand. So that's what I chose, the latter. But it definitely is. There aren't many radiation oncologists that are on the front lines advocating for Medicare for all.
Right. Another question that comes to mind that I'd like to ask, you mentioned, first of all, in your introduction, we know about your father, and you mentioned, you used the word brothers and sisters, which always makes my ears perk up, and you mentioned the word gospel, which always makes my ears perk up. And so I was wondering if you might say, if you could share about your perspective in terms of the way faith might have shaped, the way your faith is shaping who you are as a physician. I was in probably my 40s before I heard the word love. I heard the phrase, medicine is closer to love than it is to science, from Rachel Naomi Remen. And I don't want my students to be in their 40s before they hear that it's okay to have the word medicine and love in the same sentence. But that's what we haven't met in person, but that's what I'm feeling from you. And I was wondering if you could say something about how your faith has shaped your practice.
Oh, well, sure. Great question. I will say this, that, when I first got into medical school, I called home to my parents and I told them got into medical school, and I thought, oh, my parents would be so proud. And, but my parents were not your typical Asian parents. My parents actually wanted me to be a pastor, but I never felt a calling to be a pastor. Having said that, I think faith plays a big part in how I live my life, what I advocate for. And I think I'm particularly drawn to Matthew and, caring for the least among us, and viewing that as an extension of how we would care for um, God if he was walking in flesh right now, right? So I think when I look at sort of the people that wear their faith on their sleeves, who are legislating, and they don't care about our poor or incarcerated or sick, they don't care about the widow or anything along those lines, I'm like, what gospel are they reading? And I think that, but I'm not somebody who will sit there and try to shove my faith down anyone. I have friends who are from other faiths that I'm very, very close with, and I actually see a lot of God's love in the way they treat people, more so than other people that may attend the same church that I do, right? So, it is a big part of me. It is a big part of what I believe in. I have actually a tattoo from Micah 6:8 that says, seek justice, love mercy, walk humbly, as a constant reminder of what I think we should all, at least what I need to aspire to. But I do try to subtly share what, in the end, it's all about loving each other, right? And love, forgiveness, and having compassion for one another would make the world a whole lot better if we had that.
Yeah, I like to talk to our students about the fact that hospitals were Christian institutions. There's a reason why they're called Providence. There's a reason why they're called, Methodist Hospital, St. Joseph's, and that these are Christian institutions. And so I feel strongly about trying to reclaim that Christian voice in healthcare, which is what I hear coming from you.
Well, we just need to, I think in general, we need to take back the Gospels and make it less about judgment, condemnation, and certainly if you are concerned about life, well, healthcare for all will save a lot of lives too. So I think that's what I try to do.
Thank you for that. Dr. Body, there's some other great questions here. I'm going to pitch it to you.
Yeah, so one is actually in the same vein. Someone wants to know what role or roles would you want to see the faith community play in helping to restructure our healthcare system?
I would say this, that if I wish more people of faith would speak up about the mission to take care of the least among us, and the that it's not when you look at the book of Acts, right? I think that's the closest thing to socialism that I would say. Everyone, it's not Karl Marx or Lenin. It's the idea that everyone gave up their possessions, gave it all together, and gave it to whoever was in need. I think, look, we can still be successful, try to take care of our families and enjoy nice things. I'm not against anyone doing that, but I do think that when we, as one of the richest nations in the world, cannot meet the basic needs of the least among us, and yet people are saying we're this Christian nation, well, I don't know where the disconnect is, or they're just takers, because you never heard Christ say that in the Gospels, calling people takers, right? He was really looking at the most marginalized as the most blessed among us, right? That we need to do a better job of taking care of each other. I think in that sense, if we could fight back and really share what the true Gospels are about, I think that would go a long way to helping.
Yes.
So really trying to help us change the narrative of how we see our faith shedding a light on healthcare.
Exactly, and somewhere, the prosperity gospel has taken over faith, and I'm sure as you talk about many aspects of faith with various speakers, I never heard Jesus talk about prosperity. He actually railed against wealth, at least what I remember. I never saw it go by a mega mansion. It was more like, oh no, I'm not going to be able to get through the eye of a needle type of thing, right? And so I do think that there needs to be a balance, but there needs to be sort of it's been hijacked to the point where people are more concerned about maybe tax cuts than how we're going to help our least fortunate. Again, I call them brothers and sisters because we're all in one community, one way or another. Yeah.
We got a shout out here. Yes, to Micah 6:8, Dr. Song, you're speaking my love language. So I'm going to resist the temptation to ask you to show it. So,
I will send a picture. It's a big one on my back.
Okay. All right. So here's another great question. Who says it's basically clarifying the myth in this country that universal care is socialism or communism, and the fact that, how did universal health care become a thing that's called socialist or communist? And the asker here says so many things in our society are subsidized by the government that all of us use. So what do you say to somebody who who trots out socialism and communism?
Well, first of all, I would try to explain to them what socialism is. And again, at least within the context of healthcare, socialism is where the government owns and operates all aspects of the healthcare system. So the VA system is that. And if it's good enough for the military, well, it can't be so bad that a socialist system takes care of the military. And then as far as in just terms of socialism, I just found out yesterday, Katie Porter, who's a representative from California, had one of the oil executives, and I think maybe the person was actually from Texas, and basically called out the socialism that exists for the oil industry, the amount of subsidies and tax breaks that we give to the oil industry. Unlike other companies that have to depreciate expenses over a long period of time, oil industries, when they drill, they can deduct all of the costs of that in the first year. And that's a tax break that is paid for by all of us. So if you're looking at something where the whole collective community pays to subsidize a certain population, that's socialism there too. So, unfortunately, it's been demagogued in a way that is bad. But nobody's advocating for a socialized healthcare system. No one's ever said they want the government to run Baylor's Medical Center and everyone to work for the government. What they're saying is just the insurance industry, instead of having this fragmented system, we're just going to put it all in one pot, make it more efficient, and all of that savings that we'll have, because we won't be wasting money on administrative waste, will go to insure everyone and raise the level of care. So right now, seniors only have 80% of their care covered for, but if you take that administrative waste away, you now can have it where you cover 100% of their expenses instead of 80%. And at the same time, again, more money for long-term care instead of administrative costs. So, people are going to spew out that, but if you can really just calmly let them know what a real socialized system is and how I've not heard one candidate ever say that's what they want here in the United States.
Right. Yeah. Well, a lot of people in our audience are students. And like I said, if they couldn't join today because of another class, they're going to be able to watch this video. What would you say to the 18 to 22-year-old crowd who are getting ready to go out there? Many of the students in our audience today are they're not all going to be physicians by any chance. I mean, they're going to be, the way I like to say it is working in or around healthcare. So social work, healthcare policy, healthcare administration, love getting my hooks in those healthcare administration students. What would you say to this group of students? What would be your word of encouragement or advice, or kind of as we send them on their way today, what would you want to leave them with?
I would just say how inspired I am with this generation in terms of, so I was very much involved in Senator Sanders' campaign, and I saw a lot of younger people getting involved, and the urgency and the sense of overall community and what we need to do to make society better for everyone is so far ahead of what I remember when I was 21, 21. It's just a different group. The way you treat one another, the way you look at everyone holistically versus, constantly trying to pigeonhole them into an area, whether it be marriage equality, whether it be environmental issues. I believe the young people have taught the older generations a lot in terms of what's important and how things should be viewed. So I'm actually inspired by you all. I hope you guys, I'd like to see you all leading hospitals, leading community centers, and just bringing about the needed change that unfortunately my generation and older has not been able to do.
Great. Well, thank you so much. Thank you so much for a very stimulating conversation. And we look forward to having many of our students listen to this presentation and have future conversations. We're so grateful that you could join us today.
Well, again, thank you so much for having me. I'll send you the slides, and if anyone has questions, they can reach out to me directly at paulysong@gmail.com. But really grateful for you all and the work that you're doing, and for the classes, this class that you're teaching. I wish I had it when I was in college, but thank you so much.
Thank you, Dr. Song, and thank you for our moderators, Dr. Body and Dr. Barron, for moderating these questions, and thank you to the audience for being engaged. And just, I think we're all leaving here learning. Well, not only did we learn new things, but I think we're aware of these root causes of disparities, inequities, and how we can be better neighbors and more compassionate professionals. So thank you all for joining us. I want to let y'all know that we will be having another presentation in 2 weeks on March 25th. So be on the lookout in your emails for that invite link to sign up, as well as some other ones in the month of April. I also wanted to remind y'all that as Baylor ID card holders, y'all have access to discounts around the community. And this is another good way to just be better neighbors, support our local economy, and support our community. So thank you all for joining us, and we wish you a great rest of your day. Thank you.